Sir, it's 3, 2, 1. We are live now. You can start, sir.
Good evening, everyone. It's my pleasure to have Dr. Seema as a speaker for this session. First, I'd like to thank the Sun Pharma for making this session a wonderful, making this as a more interactive session. So I would like to introduce Seema. Seema has been a finished DO from Regional Institute of Ophthalmology at Chennai. Then she did a national board DIP&B at Arvind Eye Hospital, Pondicherry. After that, she did a 1.5 years cornea fellowship at Arvind Eye Hospital, Pondicherry. She is a very well-renowned person, especially she has done a lot of studies on fungal keratitis with UCSF. And Dr. Seema has been a cornea and refractive surgeon for past 8 years working with me, 5 years at Pondicherry and 3 years at Arvind, Chennai. She has a vast knowledge on treating the microbial keratitis. As you all know, the leading cause of microbial keratitis is one of the leading cause of corneal blindness. So if you can intervene this microbial keratitis at the early stage, we can prevent the corneal blindness. But the major challenge now we face is the fungal keratitis, the newer fungal keratitis like the pythium keratitis, which she will be touching upon. The majority of the corneal ulcers, as a postgraduate, you will be able to you will be able to identify clinically whether it's a bacterial or a fungal. So you can, without any lab facilities, you will be able to clinically diagnose this keratitis. As a postgraduate, first you should know, should have a good knowledge about the presentation, the symptoms about the keratitis. Once you're having a good knowledge, it's easy to diagnose the microbial keratitis clinically. 80% of the keratitis can be diagnosed clinically. So Dr. Seema will be speaking on microbial keratitis, where she will be talking about bacterial, fungal, the newer fungal keratitis like the pythium keratitis, and also she might she'll touch upon the microsporial keratitis. Over to you, Seema.
Thank you very much, Dr. Thiru sir, for that kind introduction. I welcome all the postgraduate students and all those interested in learning more about microbial keratitis at this point. I am trying to share my screen now. Is my screen visible?
Yes, ma'am, it is visible.
I will just put it in slideshow. Yes. Okay. Let me start by saying microbial keratitis is nothing but literally the bugbear of ophthalmology. As you all might be knowing, bugbear is an archaic feature to, scare off children and to say that if you don't listen to me, the bugbear is going to come and attack you. It's like a fearsome and most cruel kind of archaic, Rakshas kind of a thing that people talk about in stories, something which has to be very scared about. Similarly, in ophthalmology, something that we all are literally fearful about is nothing but microbial keratitis. It's nothing but the microbugs that invade the eye. Microbial keratitis, as you all know, is also known as corneal ulcer, right? So when I say to my fellows or my postgraduate students, define an ulcer, the first thing that comes to your mind is your typical description of an ulcer, the definition of an ulcer in surgery that we learn as breach in the continuity of the epithelium. But is breach in the continuity of epithelium enough to call it an ulcer? That's nothing but an epithelial defect as far as the cornea is concerned. You see, this is a clear epithelial defect which is stained with fluorescein stain. Is that a corneal ulcer? No. Then what is a corneal ulcer? When there is breach in continuity of the epithelium along with infiltration of the corneal stroma with polymorphonuclear cells or leukocytes with other features such as corneal edema, which may also be present, then it is known as a corneal ulcer or a microbial keratitis. Keratitis is nothing but inflammation of the cornea or some of the layers of the cornea. As each and every disease in medicine is classified most commonly as infectious and non-infectious, so is the case with keratitis. Keratitis can also be classified as infectious or non-infectious causes. Infectious causes most commonly in are microbial keratitis like bacterial or fungal keratitis. Non-infectious causes can be exposure keratopathy, exposure keratitis because of lack of thalamus, or other systemic diseases such as collagen vascular diseases, rheumatoid arthritis, etc. that can cause peripheral ulcerative keratitis, something like a flictonular or a marginal keratitis. These are the non-infectious or autoimmune causes of keratitis. What are the predisposing factors? The most common predisposing factors in our setting are extrinsic, that is, some trauma related. More commonly in the Western world, it is, or in the urban area, it is contact lens related, but also previous ocular lid surgeries or medications can also cause keratitis. The ocular surface is a very important aspect that can prevent infections from happening. So if there is a good tear film or a good ocular surface, that itself is the primary barrier to infection. Any disruption of the ocular surface or abnormality of the lid margin or misdirection of lashes can cause keratitis. Corneal epithelial abnormalities because of poor sensation such as in neurotrophic keratitis or other viral conditions can also cause further keratitis. Of course, systemic conditions such as diabetes, connective tissue disorders, leprosy, immunocompromised status can also contribute. Coming to the general symptoms, as in most conditions related to the eye, there will be pain, redness, watering, photophobia, and decrease in vision. It's an acute condition. When we come to history taking, it's very important for us to know what is the occupation. That can give you important clues, such as whether it's a farmer by occupation or it's an industrial worker by occupation, or in some cases, the occupational or the other history may not be corroborative. Ocular symptoms have to be looked into. There has to be a prominent history of trauma, which has to be asked even if the patient is not forthcoming with it. Particularly in our situation, we have to ask history of native medications or use of any other over-the-counter drugs or prescribed by somebody whom the patient has been seeing before coming to you. Native medications in our setting commonly are breast milk, or patients even use chicken blood. We have had patients who have used the slime of snails. They say in Tamil, natte. So these are the things which, or even green leaf juice, all these native medications are important features that could actually contribute to the infection. It would have been a benign trauma to begin with, but by using these native medications, there could be secondary infection in the cornea. General appearance, whether there is malnourishment or there is any other features of collagen vascular diseases, if there is any asymmetry of the facial features, whether there is any zoster related appearance, whether the eyelids close completely or not. This is a very important thing which we may miss, and that could be really the cause for the underlying cause, which if addressed, the ulcer could be treated well. Another important thing which can be hidden is the nasolacrimal duct apparatus, checking of the Rho plus, that is regurgitation on pressure over lacrimal sac area, is very, very important. Whatever said and done, if you have hundreds of drugs to treat, but if you don't cause treat the underlying cause, your ulcer is not going to heal. So I would like to remind you all of the 5 S's of examination of a corneal ulcer case: stain, sensation, smear, sac, and sugar. So these are the 5 S's, very importantly, especially for exam going PGs. If you take your history properly and examine with these 5 S's in mind, you will most often not miss the diagnosis. Then coming to the stages of corneal ulceration. As you see, the corneal ulcer goes through 4 stages. First, is the stage of infiltration, and then comes the stage of progression or progressive infiltration. Here, where the ulcer margin actually overhangs. This clinical photo shows you an epithelial defect with surrounding infiltration. The whitish area is the infiltration with leukocytes. So here, very clearly in this picture, you can see that the epithelial defect is smaller than the size of the infiltration. As the ulcer continues to progress, then as you start giving medications, there is some amount of regression of the ulcer or the infiltration that happens. In these cases, the epithelium continues to slough, but the stromal reaction starts to regress. Your epithelial defect in these cases may go beyond the area of the ulceration or the area of the infiltration. That is called the area of regression, as is shown in this diagram, as is shown in this picture. If you see closely, though the area looks quite white, around the area of the white ulceration, you can see a grayish zone which shows healing. After beyond the stage of regression comes the stage of cicatrization. Cicatrization, as you all know, is nothing but scarring. Cornea is a transparent structure, and when healing happens because of inflammatory reaction and vascularization, the cornea is left with a scar. In the visual axis, this can be vision threatening, as is shown in this picture. So this is a picture of a corneal ulcer, typically could be your exam case. So when you see this, I want you all to remember that you have to give a very good diagram of a corneal ulcer. So what all features that you see in a case like this, you could represent as a color-coded picture. Okay, so the picture may not be, I have tried to do it as well as possible with the, paintbrush here, but this green zone, I would like to know, like you all to know that there is a specific color coding. An epithelial defect is shown as green. So you see this green outline here. You should always give a head-on picture, a diffuse picture diagram along with a slit picture diagram. So whatever you show in the diffuse picture has to be shown in the slit picture as well. So the green epithelial defect margin is shown as an epithelial defect here on the slit. Beyond the epithelial defect is the stromal infiltration, that is shown in yellow. And the stromal infiltration, as seen on the slit in this particular case, is restricted to the anterior 1/3 of the cornea. Beyond the area of stromal infiltration is the cellular reaction, is the WBC cellular reaction, which is seen as stippled, fuzzy kind of a reaction in the stroma. That is shown as stippled blue color. Beyond that is a diffuse area of stromal edema, which is the light blue color that you see here, and diffuse stromal reaction and stromal edema as shown in the slit picture. Vascularization is shown in red as red twigs. An endothelial plaque, which you can't make out very well in the head-on picture, but you can see here in the slit picture, is also an important feature of progressive keratitis. And a hypopyon, which fills the anterior chamber, the level of hypopyon as shown in the slit picture here. So these are the features, along with the circumcorneal congestion, which is defined as the red lines outside the cornea. Coming to the pathogenesis of a corneal ulcer, it could be due to various causes such as trauma, contact lens, or epithelial disease. The organism causes damage of the edges of the corneal epithelial cells, especially the glycocalyx. It causes interaction of the adhesins with the glycoprotein receptor of the ocular surface. Essentially, I want you to understand that it causes epithelial damage and then further binds by releasing other enzymes like proteases and bacterial cell surface protein or other organisms which cause cell surface protein. It invades the epithelium and goes into the stroma. In the stroma, it goes and further replicates. This causes proteolysis and degradation of the stromal collagen within the cornea, and that causes the ulceration. This is part of the pathogenesis. So what are the pathogens actually that cause corneal ulcers, microbial keratitis? Apart from bacterial, fungal, and certain other organisms, there are the whole set of viral domain is there, which is a separate entity altogether, which I would not be covering in today's talk. So we will be restricting to pathogens other than viral. Most common causative organisms are Staphylococcus epidermidis and Streptococcus pneumoniae. Pneumonia especially associated with sac infection. As you know, it's a commensal of the respiratory tract. And most common associated with contact lens is Pseudomonas and sometimes even Staphylococcus aureus. This is a favorite question of many old-timer examiners, so all of you ought to know these are the organisms which can invade the intact epithelium. Even when there is no defect of the epithelium, they can penetrate the intact epithelium. These are nothing but Corynebacterium diphtheriae, Neisseria gonorrhea, Haemophilus aegyptius, Listeria monocytogenes, and Shigella. Coming to fungal pathogens, there are various fungal pathogens as per the classification of fungi, but what are important to us from the corneal ulcer perspective are filamentous septate and sometimes filamentous aseptate fungi as well. So Fusarium, especially Solanae, very common in the South Indian population, even in the North Indian population. I'm giving you mainly an Indian perspective. Of course, Aspergillus, Fumigatus, Flavus, Niger, these are demataceous, that is pigment producing fungi. Apart from these, certain others such as Alternaria curvularia also could cause ulcers. Now, I would like to have an interactive session. All of you PJs out there could even put in the chat box as to what you see here. This is an ulcer, which is a round, well-defined margin and a very, very wet-looking ulcer. Can you all tell me what kind of an ulcer this could be? If you know what it is, you could just put it in the chat box. The similar kind of ulcer, when it progresses, it could involve the entire cornea, limbus to limbus, and start threatening even the sclera. So here is what you see is a Staphylococcus aureus ulcer, a bacterial ulcer. I want you to have the take-home message that bacterial ulcers are well circumscribed. The margins are regular, most often rounded, and then you see a very wet-looking ulcer when there is collagen or tissue melt happening in the stroma that causes the wet appearance. This, on the other hand, is a very aggressive Pseudomonas ulcer when the whole cornea is almost going for a melt. The anterior chamber is filled with exudate. So that is one of the worst situations with a bacterial ulcer. Is it possible for me to see the chat box here, Mr. Ankit? Okay, nevertheless, I'll carry on.
Yes, ma'am. You can carry.
I can't see the chat responses here.
Chat response I can see Seema, because
Okay. So Dr. Thiru can see the chat responses. Let's see if you're getting it right. Next slide. Here you see a very dendritiform kind of ulcer. So when you look at this, you may confuse it with a viral keratitis, which causes epithelial dendrites that stain. But what you see here is stromal, feathery, dendritiform lesion. This is nothing but a fungal ulcer. Demataceous fungi or pigment-producing fungi can cause surface pigmentation. If you look closely, this picture can show you feathery margins. And as against the previous picture, this is a very dry-looking ulcer. There again, here you see a picture of a very large, dry lesion with a surface plaque. Can you see this? It looks as if you scrape it, it will come out in toto. That is called a plaque. And a large hypopyon filling almost half of the anterior chamber. Another important feature, these are features typically what you see in fungal keratitis. So here you see a fungal keratitis plaque. The margins are feathery. There is a small convex hypopyon here. But interestingly, apart from this main lesion, there are also other satellites that you see here. So these are typically called as satellite lesions, which are typically seen in fungal keratitis. Okay, can you all guess what this is? This is typically, like you see, a very pearly kind of infiltrate, discrete pearl-like infiltrate in the stroma. And this particular lesion shows something like a wreath-like appearance, a wreath made of flowers. This looks exactly like that. This is called, this clinically you can, these are features, very typical features that I'm telling you about a particular microbial keratitis. This is nothing but a nocardia keratitis. Nocardia keratitis can be seen with some injury with soil or even with contact lenses. But typically, many times you see nocardia infections immediately after surgery around the area of the wound, say after a cataract surgery around the main incision or around the side port. This is a case of post-operative nocardia infection. Here was the side port in this particular case, and you see a nice circumscribed nocardia keratitis lesion sitting there. So some atypical keratitis, I would deal with the treatment right away, and the general treatment I would come to later. So nocardia is typically treated with amikacin in the concentration of fortified amikacin, the concentration of 2 to 2.5 or even up to 4%. This is the monotherapy treatment of choice for nocardia. It is prepared from intravenous injection amikacin. Next up, you see this particular, these pictures show you lesion of very discrete but kind of crystalline looking lesion. If you see this particular infiltrate, though it looks feathery, the feather is not very, fuzzy. It's very sharp, like a crystal. This is called as a cracked windshield appearance, typically seen by microbial keratitis due to atypical mycobacterium or non-tuberculous mycobacterium as it is called. Can you see what this is? This is actually radial keratotomy cuts given in a patient who had undergone radial keratotomy some time back. It's an old picture which shows this crystalline kind of cracked windshield appearance. Mycobacterium, non-tuberculous mycobacterium is typically associated with post-refractive surgery, such as post-LASIK or post-RK situations, and are difficult to treat as well because they happen in the plaque interface. The treatment is usually with aminoglycosides or macrolides. Amikacin and even fluoroquinolones, the newer generation ones, can be effective, but they describe clarithromycin prepared topically from oral suspension granules to be effective as well, along with topical azithromycin. Coming to the next picture, I would describe this as a ring-shaped infiltrate. It doesn't look very dry. It's ring-shaped. The margins are not typically feathery. And here you see something like radial lines in the stroma with some neuritis around it. So this is called radial perineuritis, and this is called the ring-shaped lesion. Typically happens with acanthamoeba keratitis. Acanthamoeba is a protozoan which causes very painful and very recalcitrant keratitis, very, very difficult to treat. Sometimes it can cause limbitis and scleritis as well. And it can actually further progress and deteriorate, causing suppuration, thinning, and involvement of the total cornea when it becomes non-responsive, wherein you may have to go for a therapeutic keratoplasty. So these are the various drugs that can be used for acanthamoeba treatment. The thing is, when you have too many drugs to treat a particular condition, you know that no one particular drug is actually effective. So when you have too many drugs, none of it really works very well. But the most important drugs in this list that you need to remember are PHMB or polyhexamethylene biguanide. This falls under the group of antiseptics, as also is chlorhexidine. The other drug would be propamidine, or which falls under the anti-amoebic group of drugs called as diamidines. So these are the drugs that we usually use for the treatment of acanthamoeba keratitis. Next up, if you see this stippled kind of appearance of the corneal epithelium with surrounding injection of the cornea, sometimes can be associated with corneal edema and KPs as well. Sometimes can go to threaten the limbus. But typically, this would be the picture. This would be the clinical picture that you would see. This is nothing but a microsporidial, another protozoan. It actually was described earlier that microsporidial infections are two categories, one that compromises immunocompromised individuals and one in immunosuppressed, immunocompetent individuals. Earlier, they used to say that the keratoconjunctivitis kind of picture happens in immunosuppressed or immunocompromised individuals such as HIV/AIDS, but now we see it commonly even in immunocompetent individuals. The differential diagnosis would be something like an adenoviral or a herpetic viral keratitis involving the corneal epithelium. Topical fumagillin, which is naturally secreted by Aspergillus, which is a fungus. This fumagillin is known to have an inhibitory effect on this protozoan. But we have seen fluconazole, which is available commercially, which is an antifungal drug, also to have good response, microsporidia to have good response against fluconazole. Topical propamidine also has been described to have effect against microsporidia. Like I said, we will continue with the pathogenesis. Once the cornea is infiltrated with the organism and the changes in the stroma start to happen, then you have the death of epithelium and keratocytes, further spreading to the endothelium and the anterior chamber. There is chemotaxis of the neutrophils that happens. The neutrophils involve the cornea via the limbal vessels and the tear film. Then it goes via two pathways. If there is phagocytosis and control of the replicating organisms or bacteria, then wound healing comes into picture. Vascularization helps this wound healing. Collagen resynthesis starts happening and reepithelialization happens. This is how a corneal ulcer heals. But on the other hand, if the infection goes beyond control, there is the inflammatory chain also, which is exuberant. And then there is so much of secretion of lysosomal proteolytic enzymes and collagenases that it eventually causes perforation of the cornea because of melt of the cornea. So these are the two ways in which a corneal ulcer can progress, either healing or perforation. So this is a picture where you see this was the ulcer, which started regressing with the healing margin and eventually it scarred. But on the other hand, this is the picture of an ulcer which did not heal. This is the progressive margin of the ulcer, and here is a lot of corneal melt that happened. And then eventually there is a large perforation with prolapse of the iris, which is seen here. So coming to important differentiating features, this is again a very important exam question that examiners would ask you. What are the differentiating features of bacterial and fungal? Typically, symptoms more than signs in bacterial and signs more than symptoms in fungal. Acute onset in bacterial and chronic in fungal. Discharge is purulent in bacterial and mucopurulent in fungal. Corneal sensation, this is something which is of debatable, intact or not. It really depends upon the corneal nerves that are affected, can be decreased even in bacterial. But fungal, you will have a plaque and usually the sensation would be low. And as I told you, a lot of slough and melt and wet gooey material in bacterial, and a dry feathery looking ulcer with satellite lesions or surface plaques or an endothelial plaque, which also is typical of fungal ulcers, and with an ill-defined margin in fungal keratitis. The hypopyon in bacterial is usually sterile. There is no organism in the hypopyon, whereas in fungal, you will see the fungal hyphae and filaments inside the anterior chamber. You may not see it clinically, but that gives the convex dome-like appearance of the hypopyon in a fungal ulcer. It won't change, the position of the hypopyon won't change as the patient's head posture changes, but in a bacterial, it's more liquid. It's only neutrophils, and the head position causes change in the position of the hypopyon. Response to treatment is better with fungal than with bacterial, than with fungal. Coming to an important newer emerging organism known as pythium keratitis. Pythium is actually an oomycete. It's an aquatic algae, and it's a rare cause of life-threatening infection in humans. Pulmonary infections can happen, but it's also a plant and animal pathogen. More importantly, a plant and animal pathogen. Why is it difficult for us? It is very, very fungus-like. The clinical features are also very similar to fungus. And again, it has a very fast progression. As against fungal, pythium progresses very fast. And by the time we understand that this is not a regular fungal infection, it's actually pythium, it would have damaged almost the entire cornea. So these are certain features of pythium that you can see clinically. It looks very much like a feathery fungal ulcer, but you see these tentacle-like lesions coming out of the main infiltrate. You can have peripheral guttering that is seen in this particular picture, and stippled kind of granular extensions from the main mass. These are features, and this again shows a peripheral gutter here. These are features which are typically described with pythium keratitis. On the culture plate, this is one of our culture plates. It shows a very dry and flat kind of growth with a filiform margin. And gram stain again shows a very thick walled and hyphae. With the hyphae is where you get confused with the fungal. This is where you see fungal like hyphae, but you have vesicles inside the fungal filaments. This is a KOH mount showing pythium keratitis, but vesicular appearance and very sparse septae, as you see in this Gram's picture, very sparse septae. And this is called the zoospore formation within the vesicles. Before the zoospore burst out, this is typical of pythium keratitis. Medical management is very difficult, and it has been described as 0.2% linezolid and reconstituted from the intravenous preparation, and 1% azithromycin drops can be useful. Topical itraconazole also has some benefit along with systemic azithromycin. Coming to the laboratory diagnosis of corneal ulcer cases as such, you would want to do a blood sugar, like I told you, in the 5 S's, and a complete blood count. Apart from that, the microbial workup would be a smear and a culture. You could also take a swab from the cul-de-sac to give you diagnosis hints. But typically, the cornea is anesthetized with 0.5% proparacaine, and a Kimura spatula or number 15 blade can be used to scrape the surface of the cornea, the progressive margin as well as the base of the ulcer, and then it is streaked on the culture plates or the slides, initially on the slides and then on the culture plate. Various types of samples can be from the eyelids. Also, there can be, in cases where you can't get the diagnosis in a straightforward manner, you can go for a small bit of tissue from the cornea. It's called a corneal biopsy. Actually, you're not doing a histological section here, but you're taking a bit of the cornea and then plating it on a culture plate. You can take an anterior chamber tap, or even contact lens, which has been in the eye, can be given for culture. Or sometimes in deep keratitis, when you can't scrape from the surface, the organism, the infiltrate is deeper, you can take something called as a suture biopsy. A polyfilament suture, like a Weichel suture, can be passed deep into the infiltrate and brought out through the cornea. And then that bit of the suture can be plated on the culture medium. Coming to gram staining, as you all know, bacteria can be gram positive or gram negative based on the gram staining method. First, the slide is fixated, then crystal violet stain is applied. The iodine treatment is a mordant, after which decolorization is done with alcohol. If the organism decolorizes, then it takes up the counter stain. If it doesn't get decolorized, then it is stained with the initial stain, that is the crystal violet. So gram positive are those that are stained with crystal violet and look blue in color, and gram negative are those which decolorize and then get counter stained with safranin, and that is what is pink in color. So these are the various organisms that you know about. Gram positive cocci and gram negative bacilli are what we usually deal with. So this is a picture showing you both. A KOH mount is done for fungal cases. A 10% KOH solution with a 10% glycerol as preservative is used, and a mount is placed, just a cover slip is placed on it, and then under regular magnification, it can be checked under the light microscope for fungal filaments. Importantly, other things that you can identify with the KOH mount, very importantly, are acanthamoeba cysts, pythium, and nocardia filaments. Nocardia also has a filamentous structure similar to fungi. So Coming to culture, these are the various culture media that can be used. Typically, for bacteria, we use blood agar or chocolate agar. For fungus, we use Seborrhoeids dextrose agar or potato dextrose agar. And for anaerobic organisms, if you suspect, you use thioglycolate broth. What we typically do in our clinics is C-streaking of the culture plate. This is called C-streaking. Can you see that we've streaked the material from the cornea as in the C-shaped pattern? So you see around 6 C's, 3 in the top line and 3 in the bottom line. An important reason why we do this C-streaking, as shown in this picture, is when you start streaking with the C, the organism that is actually in the cornea starts to grow along the C. Okay. And if you see organism growing elsewhere, something like this particular, colony here is not along the C. These two colonies here are not along the C. Those colonies that are not along the C are considered to be contaminants. While these, can you see this golden yellow kind of colonies, typically of Staphylococcus aureus? These are the this is the organism which is actually responsible for the ulcer. But these colonies that are growing besides it away from the sea are just contaminants because of the lab setting. This is a case of nocardia, and this is a contact lens, actually a bandage contact lens from a patient that was plated on the culture plate, and see how fulminantly growth has happened. This is a nocardia infection from a contact lens. This is an antibiotic sensitivity test. After the culture has grown the organism, it is subcultured, and curvebore disc diffusion method is used, where antibiotic pellets are kept in the culture media, and you can see the zone of clearance along the tablet. These are actual antibiotic tablets which are put into the culture media, and you can see the white area is where the organism is growing, but the clear area is where the organism is not there, and that is because of the effect of the antibiotic pellet. So this tells us to what organism to what antibiotic the organism is actually sensitive, and based on that you can decide the treatment for the patient. Coming to management, the general measures are a high protein diet, maintain proper hygiene, and give dark glasses to prevent photophobia. But apart from that, based on our microbiological diagnosis, we would decide what antibiotic to give in cases of bacterial ulcer. Fluoroquinolones are most common broad spectrum monotherapy that we use, because they tackle both broad spectrum and both gram positive and gram negative organisms. They are virtually effective against a multitude of organisms. We usually start with a loading dose every 5 minutes for 15 minutes, every 15 minutes for 1 hour, every half hour for the next 6 hours, and then hourly during the daytime and 2 hourly during the nighttime. This is the structure in which ideally the corneal ulcer should be managed with a loading dose. Coming to antifungal agents, there are various antifungal agents available, but most important are the polyenes, which are natamycin and amphotericin B. And of course, now the upcoming group of triazoles, which has voriconazole along with fluconazole and itraconazole. Coming to the important landmark trial on microbial keratitis because of fungi was the mycotic ulcer treatment trial by the Arvind and UCSF, that is the Proctor Foundation group from USA. This trial showed us that natamycin is better than voriconazole treatment for smear positive filamentous fungal keratitis, and that at least in our setting where we have a lot of fusarium keratitis, voriconazole should not be used as a monotherapy in filamentous keratitis. Coming to the various other routes of administration, you can have subconjunctival, intracameral or intrastromal administration of drug, especially in recalcitrant cases, which happen most commonly with fungal keratitis, where the absorption of the drug into the cornea also is low as compared to antibiotics, where bacterial ulcers are treated well because the absorption is far better than antifungal agents. So intracameral or intrastromal indications would be when you have a deep ulcer with infiltration or recalcitrant, like I said, or when the limbus or the sclera is being threatened, or when there is an endothelial plaque which is deep. Of course, when there are endophthalmitis episodes as well, along with the corneal ulcer. But again, we did a trial when we recent trial published in 2019, done again at Arvind Pondicherry along with UCSF. This was called the MALIN, or the Mycotic Antimicrobial Localized Injection Study. Here we found that primarily, if you use intrastomal injection primarily along with antifungal eye drops, that is topical drops, you don't have much use of a primary. We just wanted to know if we treat the patients with the intrastomal injection to begin with, can we restrict the progression of the fungal keratitis? Unfortunately, we found that there is no benefit of adding intrastomal voriconazole as a primary treatment in moderate to severe filamentous fungal ulcers. But again, if it is recalcitrant or non-responsive to topical treatment, then it might have a role. Here I have a small video of an intrastomal injection. Do tell me if you're not able to see the video. I'm trying to play it through the PowerPoint. Can you see my screen?
Yes, ma'am, it is visible.
Yeah, so here you have a 30 gauge needle with a 0.1 ml of 50 micrograms in 0.1 ml of voriconazole, and this is the microbial lesion of the fungal keratitis. The needle is injected within the stroma. Be careful, the bevel is towards the side, and multiple doses are given around the lesion as if it's like a barrage laser. So it goes all around the ulcer and the injection is done. That's a short video. And you see 0.1 ml through a 30 gauge yellow needle is taken. Coming to systemic therapy has limited role in corneal ulcers, especially being tried in deep mycotic ulcers or gonococcal keratitis, where there is some role. But the limitation is systemic antibiotics or antifungals achieve very low levels in the corneal tissue, and they don't augment the antimicrobial effects of the various other forms of treatment. Another landmark study among the MUT series was the MUT2 trial. Again, this trial showed that the effect of oral voriconazole on fungal keratitis treatment, when topical is being given, if we add on oral treatment with voriconazole, was it useful? Again, we found that there was no benefit of adding oral voriconazole to topical antifungal agents in the treatment of severe filamentous fungal ulcers. We may feel that we may add on systemic, but it was found that when significant statistically was seen with a large number of cases, 238 cases were seen in this study, it was found that oral did not have much benefit. Coming to other, apart from drops, antibiotic ointments can be used, but the problem with the ointments is it is better for night dosage, but the peak effect of the medicine in the tear film is less with ointment than with drops. Non-specific treatment would include cycloplagia, either with atropine, homatropine, or cyclopentolate, typically to relieve ciliary spasm and prevent formation of synechiae and secondary pupillary block. Anti-glaucoma medications are imperative to prevent raise in intraocular pressure. If intraocular pressure is raised, then the ulcer will not heal well. We have to remember to add on anti-glaucoma medications, especially if you have a large hypopyon or so much of inflammation in the anterior segment. When to withdraw? If you have a perforation, you have to withdraw the anti-glaucoma because the aqueous is now leaking out. But if there is an impending perforation, you don't want the IOP to go high and the ulcer to perforate. In those conditions, you should definitely give anti-glaucoma medications. Supportive treatment in case of perforations or a decimetocele when there is an impending perforation would be tissue adhesive, cyanoacrylate glue, or useful for perforations or decimetoceles. Small perforations less than, they say less than 2 millimeters, but it really works for less than 1 millimeters. And along with a bandage contact lens to support would cause, at least in a timely manner if used, will help in healing. Surgical management would be debridement of the ulcer along with other agents such as iodine or carbolic acid can be used for a chemical cautery. Finally, if nothing works, then a therapeutic keratoplasty would have to be performed. A full thickness penetrating keratoplasty could be performed. There have been described in literature cases of deep anterior lamellar keratoplasty or dark, which has been done for certain cases of keratitis. But when the ulcer is already quite progressive, it would be more useful. It would be smarter to do a full thickness penetrating keratoplasty in non-healing ulcers. So this is a picture where a large graft, this is not how you would do an optical keratoplasty, but a therapeutic keratoplasty, which means you want to remove all the area of the ulcer which is there in the cornea. Hence, you will have to go for a large graft. So when do you say that the ulcer is healing? When you have reduced pain, when you have reduced discharge, when the lid edema comes down, when the infiltration comes down, when you start seeing healing margins. These are the features, clinical signs that tell you that the ulcer is actually starting to heal. And the final thing would be the steroid controversy. So when do you use steroids in corneal ulcer? Usually we would be very afraid of using steroids because steroids is nothing but a double-edged sword. It is definitely contraindicated in fungal or suspected fungal keratitis. If you do not have a microbiological diagnosis, I would advise you to stay away from steroids until and unless you start seeing healing with the drug that you are actually using. If you don't know what the organism is, it is better. And if the infiltrate is small to moderate in size, it would be better to stop all the medications, antibiotic or antifungal, for a 24-hour period. Keep the patient under your monitoring. After 24 hours, you repeat the scraping and culture. More often than not, at this stage, you might find the organism during the repeat culture. But before having the organism in hand, it would not be recommended to use steroids. But then, is there a role of steroid? Definitely. Judicious use of steroids can reduce the morbidity of a corneal ulcer. It is definitely useful in suppressing all the inflammation that happens in the ulcer and subsequent scarring. So why then do we not use steroid frequently? Because steroid can cause recurrence of infection. It can inhibit further synthesis, or it can enhance the collagen melt that is happening. It can cause localized immunosuppression, and it can increase the IOP. So these are the negative or the cons. While suppressing the inflammation and decreasing the scarring are the pros of using corticosteroid treatment. More than 500 patients were recruited for this steroid for corneal ulcer trial, which was done again by the Aravind group. This was a randomized trial where they found that overall, there was no significant difference between the two groups when steroid was used after 24 to 48 hours of antibiotic, only in bacterial ulcers. So definitely this steroid can be a very useful equipment in your armamentarium in treating bacterial keratitis. It has reduced the infiltrate and scar size at 3 months. It has enhanced the time to epithelialization. And even in certain specific cases where the ulcers were central and visually threatening, those cases in bacterial ulcers had a better outcome when steroid was used after 24 to 48 hours of starting the antibiotic. But definitely use it with caution. Don't use it in cases of nocardia, or sometimes in cases of acanthamoeba also. You have to use it with great caution. So when do you actually use steroids? When you have a confirmed diagnosis, when you have the antibiotic sensitivity, when you start seeing the control of infection happening, and when it is possible to monitor the patient closely. So these are the tenets or the caveats that you should be heeding to when you use steroids in corneal ulcer. That's about it from me today. That's all. Thank you very much for your patient listening. All about corneal ulcers. Thank you.
Thank you, Seema, for the excellent presentation. We have few questions. Dr. Ashok has asked how to treat a patient of corneal ulcer in a remote area where lab facilities are not available.
So again, like I said, I have given you a list of features that will help you to clinically diagnose ulcers. So by clinical judgment, if the ulcer is small or a medium ulcer, then clinical judgment could be possible. But even in a remote area, if you have a little basic microbiological setup like a simple light microscope, you can use a KOH mount at least to, if you want to make out if it's fungal or not. And then you know that by clinical features it is looking more like a bacterial, then you can use a KOH mount. It has been described by people that even a magnification or a 90D kind of a convex lens which is attached on your mobile camera can also be used actually to simply magnify the KOH mount and visualize the hyphae, that are fungal hyphae or other elements that can be seen on a KOH mount. So in a remote area, these are the tips and tricks that you might be able to use, apart of course from clinical features, to diagnose fungal ulcers.
Next, there's a question from Dr. Krishna from Telangana. He
Yes,
says,
sir.
what are the most common causes of fungal keratitis organisms?
So the most common cause of fungal keratitis, like I was saying, was it's with vegetative matter, plant-based injuries. So it's commonly seen occupationally in farmers or people who are working, in agricultural industry or even in marketplaces. Typically, it is seen with this. The fusarium happens with onion peels. So vegetative matter is typically, or even dry twigs or wood or any kind of plant-based matter can cause fungal keratitis more often. But that's not the case with pythium. Though it looks very common, very similar to fungal keratitis, it may not have history with vegetative matter injury when it comes to pythium. It could just be soil or even water contamination when it comes to pythium, or even no particular history.
Just to add that the common organisms which we see is the fusarium in South India and aspergillus in North India. That's what normally we see. So we mainly wanted the common organisms. So which,
Oh, sorry. So the common organisms. I thought, what is the common cause of what causes the injury? Yes, the common organism, like sir said, here would be fusarium solani, typically in South India, and that's one of the caveats, one of the specifics of the MUT1 study. That the MUT1 study concluded that natamycin is more effective than voriconazole, and definitely voriconazole would not be used as a monotherapy. But to highlight the fact that 70% of the ulcer cases in the MUT1 were fusarium. So natamycin is definitely useful for fusarium keratitis. Voriconazole has been shown to be effective in aspergillus cases, but if there is a drug which has to be used as a single therapy or a monotherapy, then natamycin would be the better choice.
And also, just a small suggestion to all the postgraduates: never start voriconazole as a primary treatment of fungal keratitis. It's always to start natamycin, because natamycin is a broad spectrum antifungal. It's always better to start broad spectrum antifungal than going for voriconazole.
So these are the pearls or take-home messages that you should remember from today's talk, not just for your exams, but for treating your patients in future, even as general ophthalmologists, or even if you are from certain other faculty subspecialties, but you see cases in your own practice. These are caveats you should probably remember for life.
Is there any other questions? I don't think there are any other questions. Once again, I'd like to thank Dr. Seema for the excellent presentation. And also, I'd like to thank the Sun Pharma group for this very wonderful talk and very wonderful section. So once again, I thank all the speakers, all the participants, the Sun Pharma group, and Seema. Good night.
Thank you. My thanks to the Sun Pharma for inviting me for this talk as well. Thank you very much. And thank you to all the postgraduate students and other listeners. All the best. And don't forget the caveats of corneal ulcer. Thank you.
Ankit, you can stop streaming.
Okay, thank you, sir.